We're live.
Hey, are we here? We good? Okay.
Yeah.
Hey, everybody. John Kublank here. We have another great episode of Off the Cuff, all things healthcare. And if this is your first time joining us, welcome. And you have the honor, privilege, like I always do, to get to witness the words coming out of this angel's mouth, my co-host, and literally the best nurse in the world, Miss Arlene Maxim. How are you, Arlene?
I'm good. Thank you, John. Thank you so much. It's been a while since we've gotten together.
It is.
And I'm excited that I have one of my best friends, Bob Markette, on here. I'm just really happy that he's here to work with me. We're going to do a couple advertisements.
Yeah, I just want to do a little shameless plug. I know you do as well. I've been representing Hygienic Helper. Hygienic Helper is a tool for individuals with disabilities and that don't have the ability to clean themselves or reach in places behind, those sort of things. And so me and a partner of mine he invented it, and we've just launched the product about a month ago. So you can go over to hygienichthelper.com and get your tool or check out more. But that's all I wanted to say about that today. Arlene, what do you got today for us today?
Gateway Consulting, Coding Consulting is one of our sponsors as well. And they are right in the midst of all of these reviews that the hospice companies are experiencing now, as well as home care, but hospice is getting something that they haven't had in the past. So Gateway is there to help them out. So it's at www.gateway.com, gatewayconsulting.com, I'm sorry. And so they are sponsoring us today again. They are one of our frequent sponsors, and we're happy that they're able to help us out with this podcast. One of the reasons we're doing this today is certainly because it's a very frightening type of thing for home care and hospice folks to be going through. And we've had a couple instances where we've had results that weren't really good in the past couple years, with a couple nurses being actually murdered in homes where they're taking care of patients. And Bob and I have the opportunity to speak at the National Association for Home Care on this very subject next month. And so for those of you that are going to be going to NOC, we would love to have you meet up with us at NOC, and make sure you come up and talk to us about our podcast and let us know how you feel about the subject matters that we're bringing on to the show. And with that, I guess I will turn it back over to you, John, and you can introduce Bob. Bob's been on our podcast in the past.
Frequent guest, personal friend of Arlene, and I have to say mine as well, because I
was hoping you would.
Hope so. But Bob, thanks for coming back, and you have such a vast knowledge of the healthcare landscape, but on this particular topic, I think we all have to be prepared. We all have to have an understanding of what to do in these sort of situations. And, you know, we want to talk about some different scenarios and your perspective on what we should be doing as an organization or as an individual to help us prepare for workplace safety so that we can prevent workplace violence.
Well, one of the things I just want to bring up before we get started, one of the things that has recently happened is that Texas has actually put out some rules that they are having home care operators and hospice operators adopt in the state. And I see, and Bob, you probably have a lot more information than I do about this, but I see that states are now getting involved. And Connecticut, of course, is where the last incident occurred. And they came up with a number of things that the organization that was involved had to change. I expect that the state itself will make some changes related to this, but I know Texas has come up with quite a long list of things that they're requiring home care and hospices do now for workplace safety. So I'll go ahead, and I didn't mean to interrupt you, Bob, but Bob has a lot of information on on the types of policies that we need to change. One thing that I'm going to talk about at NOC is what I call the pie concept, where we have to look at our policies in the agencies, whether you're in home care or hospice. We have to look at the policies, and then we have to make sure that we are taking that information and including that in the orientation that we're doing with our staff, and making sure that they have a clear understanding of what they're walking into when they go into these homes. And then the last part of it is then to make sure that they are including that in everything that they do, and that the experience that they have is a safe experience, and that it's something that we don't shy away from. And it's not just, and Bob, I hope you talk about this too. It's not, first of all, it's not just deaths that we're dealing with. We're dealing with injuries that are taking place in the home, both emotional and physical injuries that take place at home. And I've said this in the past at other podcasts that we've done. I've experienced things myself. I've done home care in the past, and I've experienced things myself. So I know it's real. And those types of things we don't talk about a whole lot. We're talking about, keeping people from actually dying. And certainly that's important, but we also have to think about the types of injuries that are taking place as well. So the types of policies that need to be changed, I think that Bob is going to talk about that, and what types of things are legal to carry and what are not. And I'll turn it over to you.
And that's the thing, right? The deaths, there have been 2 in the last year and a half, where home care workers in the home end up murdered. And that's drawn attention to. But that's a small percentage of the risk. And the real issue that it's drawing attention to is just workplace safety generally. And I've talked about this several times in the last year. But I think what's happened is we tend to be a bit cavalier about workplace safety. And we don't really think about, it's odd for us at home care, right? Because the workplace is the client's home. We don't really think of it as a workplace, but it is. It's a workplace for the purpose of Title VII, everything else. And from OSHA's perspective, it's a workplace subject to all the federal requirements. You mentioned state regulations. I had not seen Texas come out with those regulations. I've been very busy with the hospice audits you talked about earlier, with ALJ appeals and MAC appeals. But I think you're right. Regulators get more involved. But OSHA has already put out a relatively detailed framework in terms of workplace violence, especially in healthcare. Because you look at the data, healthcare workers in general are far more likely to be subject to workplace violence than any other type of worker. Right? Workplace violence is more common in a healthcare setting. But if you look at the universe of workplace risks and injuries we're talking about, violence is one subset. In a lot of the data for home care, you have much bigger issues with what they call ergonomic injuries, lifting injuries, injuries from failing to properly use proper technique with moving patients, lifting patients, things like that. Slip and fall injuries. Your employees are at far greater risk of getting injured going into a home like after a snowstorm. In fact, I was just doing this. I did a presentation on workplace safety down in Kentucky a few weeks ago, and one of the attendees mentioned that she herself, as a nurse, had been injured walking into an employee or patient's home and slipping on the ice. And she said, it's funny because I knew when I got out of the car, I needed to be careful because we just had a big snow and ice storm and they hadn't salted anything. And she still slipped and fell and got injured. And the data from that OSHA has put out, and you also see it from the Bureau of Labor Statistics, is the amount of lost working time from these ergonomic injuries, the slip and falls, things like that, which are other factors you need to take care of. And Arlene mentioned policies, and that's where we address it, right? We have to have workplace safety policies. OSHA expects it. If you get an OSHA investigation, they're going to see them. It's just like a survey. They're going to see, what have you done? What steps have you taken? And one of the big ones that we need to take, and it gets overlooked, just like it gets overlooked with HIPAA, is the risk assessment. And actually sitting down and thinking about what are the risks my employees face. They will vary, depending on where you are in the country. Like if you're in the South, you're probably not super worried about your employees slipping and falling on ice in a snowstorm because you don't get a lot of snow down in the South.
Sure.
But like in the South, you have other risks. And I know one of our good friends, Dee Cornetti, always talks about one of her first home health visits being, she's from Florida, and she was visiting a trailer, and the weather down there, you get a lot of rain, stuff gets wet, stuff rots, and she was at a trailer where the floor had rotted out. And so the workplace risk she faced was to get to the patient, she had to do a balance beam routine across the structural member, the main structural member of the floor of this trailer, because there wasn't actually a floor any longer. And those are the kind of things where an employee gets hurt and OSHA is going to blame you. Another example, infestations. I've had more survey issues or agency with questions where a patient's home is infested with bed bugs or rodents or cockroaches, and the employees don't want to go in there, and they want to suspend services. Well, now you've got a competing interest because you've got CMS that says, no, you don't suspend services, you keep going. This is an infection control issue. So the agency has to think about, did I, in my policies and procedures on personal protective equipment infections, have I addressed these things? Because that's a workplace safety issue as well as potential. So all these things in our policies we have to think about.
I had a question in the context of hospice, right? I've had this rodent infestation thing so many times, just having to deal with, individually with my employees, with my staff, team members. And, they're not being ugly at all. It's just, it's hard for them to deal. A lot of different people, it's just hard for them to deal with certain different things. And that's fine. From your perspective, does the agency have the agency at that point to invest in some sort of pest control or one-time home cleaning to make it safe for the employees to go in?
So I hesitate with that because now we have another layer of regulation. We're home care providers. We're paid by home health hospice. We're paid by Medicare and Medicaid. Is my paying to mitigate the infestation of the employee's home, the patient's home, is that an inducement to the beneficiary? That's something of value to the beneficiary. So I always tell clients is your social work needs to work with the family. And there are community resources in through the various state welfare programs. There are ways to get, even if the family can't afford it, to get it taken care of, get it paid for through state resources or county resources to address it. The big issue is that most agencies face is the patients, the employees, they may not be mean about it or whatnot, but they don't want to go back. And so the real question is, and it can vary, right? Animals do present a slightly different risk profile than bugs, right? With bed bugs, things like that, wear your PPE if you probably don and doff it. Because what's the concern your staff has with bed bugs? I don't want to track at home. Fair. Well, if you use, and I've had this conversation with CMS, their position, if you properly use the PPE, you won't. Now, there's a whole subset there of, is the staff properly using the PPE? But I had this come up in a survey because the agency got cited for not going out while the patient had a bed bug infestation. And the state was like, no, you have to go. And we had a lengthy back and forth with the state and CMS. And the final analysis was, from a survey perspective, they did not think you should stop going out. And so the question became, with the bed bug infestation, how do you address it in your workplace safety policies? What procedures do you have in place? When you get into other things, rodents, dogs, it changes different risk profile, but you still have to think through all the different regulatory pieces that overlay the problem.
I'm sorry, John.
Oh, no. I just was thinking just real quick that I find it funny because nurses, they'll go in to, HIV patients or, some crazy tropical virus or something like that. And that's like their jam. They're ready to go. But you put a bug down, it's like, nope, too much for me. Which again, everybody has their thing.
Well, and that's what CMS said. They're like, this first time camp was right after COVID. Like, we expected you to go out in the middle of COVID. We didn't even know what COVID was when you guys started going out. So if we expected you to go out for that, we clearly expect you to go out for bed bugs.
Yeah.
Well, I do think that we have to really consider our intake process, though, because our intake process now, and John, by being an operator, you want to take as many referrals in as you possibly can. But I do think the intake process in most companies, probably 95% of them, have to change. And we need to make decisions on the types of patients we're going to take. And you don't have to take every single referral. And maybe you can address that, Bob. Every single referral comes through your door, you're not necessarily bound to take that referral. If you don't have staff, if you don't have
if you're working for a home care company, you just lost your job.
well, if you don't have resources to care for the patient, I think that we need to take a look at that and what our intake policies are. And I think that the intake departments themselves have to be much more involved in the whole process of these admissions through in home care through the discharge process, but the types of patients that we take and whether or not we're going to take certain types of patients. We've had a SWAT team member on a previous podcast that talked about how we need to be doing background checks. Now, that's not going to tell us about rodents probably, or might tell us about their pets that they have if they're not behaved well. But the background checks on patients. We do background checks on our staff, but we haven't in the past, don't necessarily done them on patients themselves. So I think that some of that has to take place. And I think that the questions that we ask at intake, and I don't know, would it be acceptable to ask if they've got any type of infestation in the home? I mean, I don't know that they'd tell you, but would that be an appropriate question to ask at intake?
I mean, I suppose it would be. You do always have the risk of a surveyor looking at your questionnaire, and I've had this happen. They accuse the agency of discriminating against poor patients, to which we're always like, we're home care. Most of our patients are poor. Like, especially, I shouldn't say funny, but it is kind of comical when a surveyor accuses a Medicaid agency of turning away poor patients. We're like, they're on Medicaid. Like, it's in the definition. All of our patients are poor. But I do think you're right. In terms of workplace safety, intake is extremely important in terms of identifying the risks, right, in advance, knowing before you go to the extent that you can, whether it be infestations, animals. I had one agency asking about firearms ownership, and my response was, you can ask, but I can tell you right now, any firearms owner that gets asked a question by someone from the government or an agency or whatever, they're not going to answer that question because they all tend to be civil libertarians, and they all tend to be very big on privacy. And I can't blame them for that. So I'm like, you can assume, there's some things you can assume. If you look at the data, like for example, firearms, there are enough firearms in private ownership in America. I think that last time I looked, there's something like 40% of households have at least one firearm. So you figure at least half your patients probably have a firearm in the home. Animals, you can ask.
In my state, 99% of them have a firearm.
Well, and that 40%, it's really more like if you're in New York or California or Illinois, it's like 0. If you're in Indiana, Kentucky, Tennessee, etc., it's probably more like 80%.
Right.
Like, and it's probably like 80% that they have 2 or 3 firearms in the home. But here's the thing: the odds are you're never going to see them. Mm-hmm. They're not a risk. There's no more inherent danger to a firearm being in the home than a chainsaw, right? Or a knife, right? The issue is irresponsible firearms ownership. So I had a case once where a nurse got shot. Now, she got shot because the patient kept a loaded firearm by his bedside, and she came into the home. She was moving for care, and she bumped the nightstand. The gun fell down. Now, there's a whole series of questions in my mind because guns aren't supposed to just go off if you drop them. Like, they're supposed to be designed to not do that. But the gun went off, and luckily for everybody, it just grazed her because it could have been a lot worse. One of the questions that came out of that was, should the nurse have had some basic firearms training to understand how to safe a weapon? Because the patient should have been stored. It should not have been in a condition where it could go off like that. That's just basic firearms ownership. But had the nurse, a lot of people have an irrational fear of various things. One of them is firearms. And so I've had some agencies suggest we might do some basic firearms training so the agency knows how to safe the weapon. My thing is more tell the patient, keep it locked up. Guns have value. Guns are like anything else, can be stolen. You should keep anything valuable locked up so that we don't get accused of stealing it later. I wouldn't say it that way to the patient or the client.
Yeah.
Well, even if we put on intake, if you have not even ask them, I agree with you that they're probably not going to tell you. But if you have firearms, make sure they're secured before our employee.
I would say valuables.
Yeah,
I'm sorry.
I had a patient,
not firearms. Be broader.
I had a patient that got transferred to my services from another company he called me, of course, and he was extremely upset. They're the worst company. I need somebody different. And I'm like, of course, yes, I'll take care
You
of
need
you.
us. We're the best.
So I called the other company, and they're like, good luck with that guy. He
Well, that's
scared
not a
off
good
your
sign.
nurse with a loaded gun. And what I found, though, again, to the gun ownership, responsible ownership, irrational fears, it's like until I had the conversation with the patient and found out what was going on and what the situation was, everybody's opinion was just sort of an opinion. And we ended up taking the patient because all I said was, hey, while my staff is there, we would appreciate that you would keep your weapons in their safe or in a place that's, they can't see them, because some of my staff get skittish about it. And he was totally cool with it. Nobody else had just stopped to talk to him,
Well, in Germany now, I don't know if you've read this or heard about this, but in Germany, the knives are the biggest problem now. It's not the guns. I think they've taken
a separate conversation, Arlene.
It's the knives that are problems. So, I mean, there's certainly more than one thing. But what Michael, the SWAT team member, was talking about was that, when SWAT teams walk in past that front door, they pretty much know what to expect. They've done their background checks. They've done whatever checking they need to have. So, and they're armed. They have the tools to take care of most everything. When we walk through that door, we don't know. And so what is it that, Bob, in your opinion, are the types of things that, we need to put in policy to make sure that we as employers, we're doing all we can to protect our employees?
Well, I think part of that is, the recon, like how much information can we get at the beginning to identify. So another area we've talked about, there's things in the home. There's obviously various diagnoses could be an issue, right? Various mental health and dementia and things like that. You may or may not be able to obtain a criminal background check or otherwise on the client. And that might not be relevant anyways, because, back when I was a public defender, every client I had his or her first entry in the criminal history. So you could have no criminal history and still be a risk.
Sure.
Other areas, though, are, where are they at? Where are they located? Maybe the patient's not the risk. Maybe the neighborhood's the risk.
Mm-hmm.
Are there others? There's some things we can try to develop in terms of location, what we can find with the client, anything we can learn from the referral source about the client, any potential issues or whether difficulties with the patient, the facility, or otherwise. But then it's also going to be, where's this patient located? Is it in a dangerous area? Is it not a dangerous area? The staff, there's going to be some limit, some ability, or I should say some issue of when we go through the door the first time, there's going to be some unknowns. The fact of the matter is, probably 99% of the cases, we walk through that front door, it's a perfectly pleasant, nondescript visit. We gather information, we leave. It's the 1% that we have to prepare for.
Yeah.
And one of the biggest things at that point are, one, is the staff situationally aware? Part of our problem is, I think, our staff gets complacent, which is good. You don't want your staff going in thinking, all right, here we go again. It's rumble in the jungle. I'm going in there to take care of it. I don't think I'm the SWAT team. Yeah. But when they go through the door, they should be perceptive enough, right? They're perceptive enough to pick up on things with a patient in terms of patient care. That same perception should be more broad to look around. And are there other signs? Is there paraphernalia? Are there, things in the home that are red flags? Are there other people in the home that cause me concern? Like that, as I'm approaching any kind of animals. The pets are usually fine. Maybe I'm allergic. That's a question you can ask in intake. And we're not going to ask about dangerous animals, because even the pit bull owners think their animals are perfectly fine. Sure, my dog mauled that 4-year-old last week, but he's perfectly friendly. That was an outlier. So I suggest ask about animals for allergy purposes. Do you have dogs or cats? Just because our staff could be allergic and we need to know that. We're not saying anything about your dog or your cat being a monster. And then you go in the home, and then the staff knows there are animals, FYI. So I think that recon and then being alert in the situation. And I think our staff also, that means when you're in the home, and this is, I've had this conversation with on the podcast before and others, like, does your staff understand things like there be somebody between you and the door? always have an exit. I remember both my boys do martial arts, and the girls did for a while, but then they discovered dance. And as much as I tried to convince them that karate was like dance, just with fists, they stuck with dance. But I remember the karate instructor would talk to them about situational awareness. And one of the things he would said was, when you walk into a room, where are your exits? Always know the exits. When you get on an airplane, most people don't anymore, but I still do because I was raised by a pilot. You always, where am I in relation to the emergency exits? Know how you're going to get out, and make sure there's nothing between you and the exit. There's situational awareness, things like that our staff need to be trained on and understand. Again, we don't want them going in there thinking that they're going to have to fight their way out. This is, they're not John Wick, but if you're alert to those things, you can avoid being put in that situation. You have a way out. I've taught agencies about teaching staff de-escalation, right? How do I, when I sense a problem, when the patient's getting agitated, if someone else is getting agitated, there are verbal strategies to avoid confrontation. I became quite adept at that in high school. I'm pretty good about saying things I probably shouldn't say. And if you see me in person, I'm not a physically intimidating guy. So I learned very quickly how to talk my way out of trouble, right? So there are things we can teach our staff to help with that, to calm the situation down, to redirect. I think probably the biggest one is our staff should always understand, if you feel unsafe, leave. If you get to the home and there's something that makes you feel safe, drive away. And I actually was helping a client with a policy this week, and I made it very clear in the policy: leave, get somewhere safe, then let us know you left. Your first priority is get out safely. And the staff should always understand, if they feel unsafe, they will not be faulted for leaving, and we'll back them up however we have to do, because at the end of the day, we want our staff to be safe. We want them to know that that's our priority. I think a lot of times staff members are hesitant to leave because we kind of drill on, we're supposed to be there. And that's, in most situations that's true. But if there's a danger, no, you get out. You get out, you take care of yourself, and then we'll deal with the danger later. Right. So I think those are some things we have to think about in terms of policies and procedures. How
I'd like to play the devil's advocate, Bob, just for a second.
Sure.
What if I feel, and I'm the devil's advocate, so I'm a bad operator. I feel like my employee, this is the third time when we've sent her out to an admission where she's felt not safe, and so she's backed out, right? And I think that she's lying, right? How could I prove, or what would be the steps that the employee would need to bring to the table to feel confident that they're being, that it's a valuable concern? Or what should the organization take to say, like we need, like, what do you mean you don't feel safe? Like, anybody could just say it, sure. But
can I address that from my perspective, John?
Yeah, please.
So I think that orientation is so important, because during orientation, you're going to pick up on those nurses or those clinicians that feel unsafe in homes, because it's different than being in four walls. It is. I mean, you don't have people around that you can call on, that you can come to your rescue. It's different. So that orientation part is in. So that employee that you're talking about, my guess is they did not go through orientation. They did not have a preceptor. They did not go out and do visits. They did not see the type of environment they're going to be in.
Of course, I don't have time for that. They got hired and I sent them out the next day.
That's right. Yep. And that's our industry's problem. Yeah. Yeah. I'm sorry, Bob. I didn't mean to interrupt you.
But...
Bob? Did Bob freeze?
Oh no, I think you're right. I think orientation is important. Wait, am I breaking up or are you guys?
You're good. You're good.
Okay. So I think the orientation piece is important because you're right. It's different. What we do is different. We send people out in the home, and there are some people that just aren't cut out for it. They're not going to like that.
That's
being
right.
out on their own, independent. But to John's point, I think too, when the employee comes back, we can't just say, hey, if you don't feel safe, leave. Then the follow-up to that is we have to investigate, because we as an employer have an obligation under OSHA to make sure we're maintaining workplace safety. So we've now had an employee come to us with a complaint or concern about the environment. So then we need to investigate to conclude, what was she concerned about, or what was he concerned about, and investigate that to conclude, is there in fact a risk?
Should we be logging that? should we be logging that in like an OSHA complaint sort of situation that they would see, even if it's not regulatory, but so if we got OSHA, they could see that we've documented.
Yes. And then you'll document your investigation, you'll document your conclusions, and then your steps. If in fact there's a risk, we then have to assess, well, what can we do to mitigate the risk? Maybe there's nothing. Maybe the patient just is a danger, or maybe one of my examples, I had a patient years ago. The family had a dog, and on the first visit, the nurse gets the door, rings the doorbell, and the door opens, and she can see the dog coming. And so she turns and runs, and the dog chases her. She Dukes of Hazzards it across the hood of the car and gets into the car before the dog. I'm kind of like, wow, that's like when she told this story, I'm like, that's impressive. I would have tried to jump over the car, hit the car, fall on the street, by the dog.
Slipped.
Exactly. And that's how I died. Away. But so there was the investigation, legitimate concern was the dog. And her fear was legit because the dog chased her and seemed threatening. And so we had to look at what do we do. The option was we just don't ever go back. That, like the patient still needs care. The interim solution was, or the intermediate solution was to say, we will only come to the house and do the visit if the dog is secured. The dog has to be in the cage is secured. If we see the dog out roaming, the visit's off. And so the family had a responsibility then to keep the dog up, because we don't know what was wrong with the dog. I don't know if the dog had a bad day, but the dog had to be locked up for us to come into the home. And if not, we wouldn't come. And so we investigated and took action.
I think it's really important when you have those conversations with patients at that time to get them to sign a piece of paper just for that extra accountability. That's something about having somebody sign. So you can call them on the phone all day long, but I find that you get way more compliance when you get that piece of paper. And then also I've been able to use that piece of paper to go back and say, remember, this was your signature. Like, we just asked you not to smoke inside while my employees are there, or we can't do the visit, because at the end of the day, we want as many patients as we can, but our staff has to be a value of 10 times more important than every patient, because they see 10, 15, 20 patients, right? So losing one nurse, we put a lot of patients at risk for them to just be able to stop smoking or put their dog up or something like that. But I find that having the signature really helps them lock in to their commitment, their responsibility.
Oh, I agree. Once we finish the investigation and conclude there's a risk, and then there's some kind of an action plan going to be put in place, we always then, I say sit down with a patient, but obviously if there's a safety factor, it might have to be a phone call with mail. But in writing, have proof that it's been delivered off, because if they don't follow the plan, we're going to discharge them. And the first thing they're going to do is call the state and complain. You're going to get a survey, provided patient rights. And we're going to show them the documentation, say, well, okay, but we also have employee rights, and our employees are at risk, and here's what they agreed to do, and they didn't do it. And your performance improvement plan, that letter to them, is going to be very clear. If you don't do these things, you will be discharged. And our for-cause discharge policies will address that.
That's right.
So we'll be able to say we followed our discharge policy, we gave them warning, they didn't do their part, and then we have all of that, because I do all this stuff. Obviously, compliance is important, but my background is litigation. And so I always come back to, what can I prove in court? And have this all written down, they've all signed off. And I've had that come up more recently, not in workplace safety issues, but in workplace discrimination issues, where we discharge a patient due to sexual harassment in the home. And they then called the state AG to complain that we had discharged this disabled patient against his rights. And I get a call from the AG. I'm like, well, hold on a second. Let's discuss all the improper things the family was doing, including every female staff member that came into the home. They asked if they'd be interested in marrying their son, and said if they would marry him, they could have the family farm. Like, the patient may have rights on the ADA, but he does. So you have to have all that document, because when you have to you're going to get a complaint, and you're going to have to defend it at survey, EEOC, or some other kind of investigation, because the patient will refuse to admit that they got discharged because they wouldn't keep your employees safe.
There again, I think we really have to be careful about the policies that we put in and our organizations. And my hunch is that most agencies, even after this last incident, have not really looked at their policies to see where they stand with that. And that's that's a huge legal risk. If you don't have a policy to cover you, or if you have one that is inappropriate, that's to cover you. What about the types of tools? Now, it was interesting. I don't know if this is true, but somebody told me, I was actually standing in line at a car rental place and talking to some people because we were in line for so long. And one of the gentlemen was from New York, and he was talking about some of the dangerous areas in Manhattan. And he was saying that pepper spray is illegal in New York. Did you know that, or have you ever heard that? So nurses could not carry pepper spray.
Well, and even if it was legal, I get asked that a lot regularly about having your staff carry weapons. I had one agency ask about arming, giving their staff members handguns. I'm like, well, let's just assume if you're going to do that, one of your staff members is going to shoot a patient's family member. Do you really want to deal with that fallout? There's so many questions about issuing weapons. And I know I've talked to some, trainer, well, if they have the right training and everything else, I'm like, no. I'm like, at the end of the day, if it's just like cars, if I have fleet vehicles, somebody on my staff is going to crash one of my cars.
Yeah.
If I give all my staff guns, let them carry guns, somebody's getting shot.
Shoot.
So then someone's like, what about a taser? Same thing. I suppose an agency by agency consideration, state law, there's a bunch of other things there. I always say, talk to your lawyer. But my gut is, I don't think we want to arm our staff. Now there is, go ahead, John.
Oh, I was just going to say, if we were so concerned about arming, we probably didn't do enough of what we've been talking about how do we have good policies and procedures to gain information, because
right.
We shouldn't have to carry weapons in a patient. That's probably one of the patients that you don't admit. It's like, hey, I'm sorry, we're just not going to admit you because we feel like we would need to be carrying to come on property.
Right. And it's just, it doesn't, there's so many reasons why that doesn't make sense. Right. There are other options. So in some communities, and this isn't perhaps as much as it used to be, but it used to be, especially if you're going into a neighborhood that was perhaps unsafe, you could get a police escort. There are some home health and hospital providers that are part of a larger hospital system. Like I was just talking to an agency a couple weeks ago. They said that their hospital said that they would, if needed, their hospital security team would provide someone to go with.
Yeah.
You could consider sending two people.
Yes.
That backup idea is something to think about. The one that I find most interesting that's relatively recent. So if you study healthcare workplace safety, hospital safety systems are fascinating. So my daughter works at a children's hospital, and I've asked her about workplace safety, and she's like, Dad, if we have a shooter, to get to, because she's in the NICU, she's like, he's got to get past 3 separate hardened security points. Like if they get to us, like there's something massively bad going on.
They're highly trained.
Yeah. There's someone being kidnapped, and it's like a Mission Impossible type thing. But so they have physical security, but then they have, and her unit doesn't because they're so far back. They have an emergency call button. But some hospitals, the staff will actually have a badge that they can call security with very discreetly, and the badge is tracked on Wi-Fi, so security knows what room you're in. Some of the badges have cameras built in, and once you hit the button, it immediately live streams to security. So security knows exactly where you are and what's going on. And we don't have that in home care. But what's come out in the last couple of years, there are several companies that do have remote alert systems where you can have your staff. It's a name badge. It uses cell phone technology, which we'll talk about the issue there in a second. But they can discreetly call for help, and it will go to a call center. The call center is to call the police, route the police. And so there's a way for them to call for. There are a couple of problems for us still, though, right? Do they have cell coverage? We have a lot of clients out in rural areas where maybe we don't have cell coverage. And 2, that staff member is still potentially waiting for some period of time for the cavalry to arrive. In a hospital, security is there quickly. So we're still out on an island, but it is another layer where, okay, you're out there on your own, but you've got somebody watching. You can call for help. We'll know where you are. And then that raises questions about, are you overt about it? Do the patients like, so for example, dear patient, if those, if you're the crazy patient that might be thinking about harming or killing one of our staff, we'll know it was you, right?
Yeah, that was my question. Do you tell them?
I've gone back and forth. I can see ours from both sides because, I go back to, back when I was a public defender, I was in domestic violence court for a long time. And one thing they would always do is issue a protective order against, and I will say alleged victim because I represented the accused citizens, but their thinking was the protective order would keep the abuser away. And I remember talking to one of the victim advocates, and I was like, but do you really think that's going to be, if the person is really committed to assaulting or possibly murdering somebody, will a piece of paper stop them? It's the same thing. If I tell you, will the fact that I've got the badge and the police will be called and you will likely be arrested, is that going to deter you in the moment? Or might it just make things worse? And so a lot of folks,
more sneaky.
Right. A lot of people think it's better to keep it, no one needs to know. And then when things are happening, that's where we've trained you on being alert, on understanding, de-escalating the situation, and then being able to discreetly alert. So while you're trying to talk them down and avoid the situation, helps on the way. But we have the technology, we have the policy and procedure, and then we have the training to bring it all together. But it's an additional tool we didn't have years ago. Years ago, you'd have to try to get your phone out during the crisis, dial 911, and there's all those things going on.
Absolutely. I think there's technology as it increases is always going to be, new tools out there. So they're going to be able to overcome these sort of things. But at the end of the day, I think it really does come down to training. I mean, we can't train enough, but I think what we don't remember from a training perspective is practice is a part of training. It's like one thing to sit down at a conference room with some breakfast tacos and everybody's charting while somebody's talking and everybody passes around a paper and signs it, to actually, hey, okay, this is an active shooter drill, or this is, we're going to test our system to see if we were put in a situation if you're going to actually be able to perform said task. And we hardly do that for our regular nursing visits, let alone, hypothetical events, right? So, but I think that's probably where lies the most important piece, is taking the time to make sure your staff actually training, and the gun safety handling. I've never even thought about that, but I'm going to do that with my next staff too, for sure.
Yeah, and that's the thing with training. It's like when you're training for HIP or anything else. You can't just do it once and walk away. It's going to be ongoing and repeated training. You have to keep at. When it comes to things like self-defense, again, the example I always go back to my boys in their martial arts, it was ongoing. Like I remember the instructor talk about the idea with, now we're not going to teach our staff to be ninjas, but the point was, train so much that in the situation it's instinctive to think about. So when the escalation happens, you have to think, well, now what do I do here? How do I de-escalate? You've trained so much, you know what to do. You're comfortable in the situation, because that's what the training has to be. So you're always thinking about, when you walk into the home, you're looking for the signs and things like that, because most of the time you're not going to need it. And so complacency sets in. Our staff doesn't think about it, because, and that's fine. Our staff is generally safe. In 9 times out of 10, 9 times out of 100, we're going to go into the home and everything's going to be fine. We're preparing them for the extreme outliers. And the other thing too is to think about the nonviolent stuff, right? The ice on the sidewalk, bad stairs, carpet you might trip on, ergonomics. OSHA's done a whole bunch of written guidance to home care and on workplace safety. And one of their big issues is ergonomic injuries. And are we properly training our staff on the lifting techniques and use of gait belts and all those things? Because of the percentage of home care workers that miss work, not because they're victims of violence, but because they injured their back or their shoulder because they didn't lift the patient properly. So that's my other concern on this, is the violence component is getting a huge attention right now, as it should, because people have died and we want our staff to be, we don't want that to happen again. But at the same time, while we're focusing on that very relatively unlikely but very extreme scenario, let's not forget all the far more likely scenarios where our staff might get injured, not because of somebody's ill will, but because of all the other components of safety in the home.
Yeah, that's true. Yeah.
Like I did a checklist, but things you can assess in the home for, we assess the home for the patient's fall risk. Isn't that the same for our staff? If there's throw rugs, there's loose carpet, like our staff might not be as likely to fall, but they could still trip on carpeted stairs. We have a cat. I swear my cat's trying to murder me because every morning when I get up in the dark and it's a dark cat, he runs under my feet on the stairs. I'm like, one of these days, cat, you're not getting breakfast because I'll be the bottom of the bed. Stuff like that we could be on the lookout for, where it's just more general safety that our staff needs to be aware of, because that's far more likely what's going to happen.
Yeah, going back to the workplace safety issue in hospice, I don't know why more hospices don't think about using their volunteer program to secure, like, retired security folks or retired policemen, or just additional folks to ride along in some of the, like you mentioned, Bob, earlier, about in some of these not a really good place to be hanging out in.
I think one of the bigger issues with that, Arlene, on the volunteer side, is the volunteer program is such an afterthought in hospital.
I know. Yeah.
And so,
but it's required.
No, for sure. But
we can't find people to pay to work, let alone folks who are going to come to work for free.
But I think if you took the time and you developed a program that had purpose, and you weren't just blank. I think one of the issues that I've always had with volunteer programs that I've walked into, and it's like, we need volunteers. Like, for what? We're like, for everything. Like, I don't want to do everything. It's like, it's better when you're very specific. Like, we are looking for, like Arlene said, like ex-military, ex-police officers, peace officers, massive bodybuilders that want to volunteer and do ride-alongs. Very simple. Right. So I think if we took a little more time to develop what the volunteer program looked like internally, then they would have those opportunities. But they just don't think about it.
No.
They don't think about it. But
so we're going to talk more about this at NOC. And again, or NAC depends on your age, is how you pronounce the acronym.
Have they officially changed their name yet? Now with the merger?
I think they changed their name. They changed the name. It's National. Oh, I can't remember the name of it. But yeah, they did just this week. But I think the acronym's going to stay the same.
And they're both. Is this going to be open to the NHPCO people as well? Is this a whole coming together now?
Yeah, they merged.
And where is the conference actually going to be located?
In Tampa. Tampa this year.
No, you don't have to go very far.
I don't.
Yeah.
And did you check the dates, Bob? Was October 22nd?
It's October 20th through 22nd, and we are speaking on the 21st.
Okay.
Oh, very nice. Do you have a time slot yet?
Actually, we do.
You want to shout out?
We're speaking on the 21st. It's session 506 from 4:30 to 5:30.
Perfect.
Oh, wow.
Y'all make sure y'all go out and talk to Arlene and Bob and let them know how much you enjoyed this podcast and how much you enjoyed them coming on. Bob, as always, we love having you on. You're such a wealth of knowledge. Anything else you want to give a shout out to, or anything else is going on before we wrap up?
No, thanks for having me.
Yeah,
always enjoy being with you guys. It's always fun.
Yeah, hopefully I can.
Bob has a really big wedding coming up this weekend. Congratulations.
First of two, yes.
Yeah, well,
I've been seeing all those TikTok videos, and I'm not sure if you saw, Bob, but where the husband brings the wife back to the dad and goes, "Too expensive," and then runs off. They're like, "No, take no returns."
The both of my sons are groomsmen because that's their sister's wedding, and my understanding there's been some discussions because apparently the other TikTok trend is the groomsmen having something orchestrated for either at the during the ceremony or right after. And at one point there was some discussion about because they'd all been to see the new Deadpool movie and the NSYNC bye bye bye. There was some discussion. They're all going to learn the choreography. I don't know how far that they had the idea the moment that they went back and watched the entire choreography. Like, okay, we can't do this. But I know they've been discussing plotting something like that. So We'll see.
Well, we'll be excited to hear how that turns out. Again, congratulations, and thank you again for coming on the show. Arlene, thank you so much. We really I appreciate you. You know I do. I love you.
I appreciate you.
Without
you, we couldn't be doing this because I don't have the technical background or understanding to be able to plug this into my calendar.
The wizard.
So,
teamwork makes the dream work. All right, guys. And for the audience, thank y'all for watching Off the Cuff, all things healthcare. We will be back hopefully soon. We normally on Wednesdays from 12 p.m. to 1 p.m. or 12 p.m. Central, 1 p.m. Eastern. Hit that like and subscribe button so you can make sure you see all of our content. Until next time.
Thank you.
Bye-bye.
See ya.
Bye.
And